Hello, everyone. We are jumping into week 3 here. Chapter 7, 7, 8, and 9 for this week are the ones we're going to go over. I'm a little bit sad because these are some of the chapters that I actually really enjoy listening to. Oops, sorry. Actually, I really enjoy talking to the class about them and kind of getting your input on these. And it's important because these are really things that you are going to be dealing with day in and day out and that you're going to see often. So, Chapter 7, Respect for the Patient's Personal Relationships. Identify major stresses patients and loved ones encounter. Understand fragility. Describe and understand questions that patients may ask themselves. And revaluing relationships. So, I know that we sort of already addressed this in previous chapters, but ways that the patient's personal relationships are affected. This is just a small list that the book sort of gives us that goes into it, but the loss of familiar surroundings in which some of these relationships are kind of easily nurtured and built. So, we see this at home. We see this when they go to church. We see this in certain activities that they do. And these are some of the things that they're going to lose when a patient becomes injured or ill. The loss of capacity to participate in their own usual fashion. Think about your daily life. Think about how that would affect you, whether you become ill or injured, or if you have been injured. How did that affect you later? Some people, it's not about just doing the activity, but not being able to be there even sometimes can be a problem. Granting of privileges to the patient by others, and also unmet expectations that the patient will return to former roles. That they'll get back to normal and everything will be fine and nothing will have changed, but that doesn't always happen, and I think that's sometimes difficult for some of these relationships to really understand. So fragility, facing the fragility of relationships. And fragility is easily broken, shattered, damaged, delicate. And this happens when either it's an illness or injury, and you start to get these stresses that come along with that. And a stress is a psychological motivator, and it can either be good or it can be bad. So you'll find that sometimes your patient might go either way with that. A negative stress is called a distress, and a positive stress is called a eustress, eustress. And you might find that depending on what's happening with your patient, they might go one way or the other. Any change in a relationship is hard, but if it's because of an injury or illness, it can be just slightly more difficult just because there are other stressors on top of it. Taking care of your mom, your family, your husband, that can cause an increase in stress and kind of make that relationship a little bit more fragile or flimsy because of how it's being treated. I see this in patients a lot that some relationships become a little bit more strained, and that's difficult to face. There are some questions that the patient may ask when they're in the relationship. Will others lose interest? Will we overcome the changes? And what certainties can I count on to help me continue the relationship? And we'll talk about each one coming up. So, will others lose interest? When they see them, will they get scared off with how sick I am or with how my injury is? A lot of family members don't know what the extent of these changes are, what's actually happening with their patient. We understand what signs and symptoms we see with a stroke because we know what to look for, but patients who are unfamiliar in the medical field won't know, and that could that might push family members or friends away. During these times, they can be a little demanding. Patients can be demanding. Personalities can change, either just because of the stress that you're going through or because of the actual illness that happened. You might become pushy or angry. You might be a little bit more reserved or quiet. You might not be able to move. Some of these things are going to happen, and you're going to have to learn how to manage them. Patient and caregivers may separate themselves from social activities, and that can put a stress on relationships if you are doing normal things that you're not doing anymore because of the fact that your family member is sick. that can be stressful. We talked about that last time, that can bring on sort of a burnout with your caregivers. Your caregiver might feel stress or shame if your patient isn't improving. That's really a lot of stress for your patient. Think about it. When you are put on this job of taking care of someone and that someone isn't getting any better, you start to feel a little upset or sad because your job is to take care of them and they're not getting better. That can be a difficult burden to carry for your family members or caregivers. Can we overcome the changes? People may not always come around as often. Sometimes because of fear or acceptance. It's hard to accept that someone is dying. And some people, their way of dealing with that almost is just to withdraw and move away. And that can be a difficult challenge for a patient. Our job, just as listed in the second bullet point, is to look at the whole picture. If you think that caregiver is not getting enough time or rest, then we need to step in a little bit. And there are services that we can help provide to our patient that our patient can get help with. There's Office of Aging, Helping Angels, home care. Those are just a few. There's a respite care that can kind of help take over, where you can either take them, someone comes into the home, or you take the family member to a place where the caregiver can get some rest and kind of regroup and rebuild themselves and get ready to move forward. But it's our job to sort of recognize that and see if we can't help the situation. If the caregiver is not doing well, the patient is not going to do well, and we need to recognize that. These are just a few facts about caregiving, which I found sort of interesting. Has anyone had to care for a loved one? I did not, but my mom took care of my Grammy for a really long time, and my pop-pop took care of her when she was sick with cancer. But usually the unpaid informal caregivers are family members, neighbors, and friends. And those people currently provide the majority of long-term care services. And that will just grow significantly in the next few years. So in 2000, there was about 20 million caregivers, and that will increase to 20 million in 2000 to 37 million in 2050. And that's an increase of 85%. 85% increase because of the baby boomer generation is retiring on caregivers, and that falls on us. Some of us, not all of you in this class, some of you are younger, but that I will most likely be the caregiver for my family. My sister is 3 hours away. She's too far. My brother's about 40 minutes. I am 10 minutes, and I am the one with the most knowledge in the healthcare field to be able to do it. But we need to understand that caregiver role can also be a burnout, and we need to recognize that as professionals and see if we can't step in. And I need to recognize it myself when I do take over in that role, that's going to happen. So can we face uncertainties? It is a big adjustment for a patient. And there are a lot of uncertainties with how this all is going to pan out. Depending on the diagnosis, depending on what the illness is or what's happening, those questions may or may not be able to be answered. Cancer. When will my pain start? How will I feel after chemo? Will I be able to walk? How long can I use the bathroom for? Those kind of things. These are all uncertain questions that your patients are going to be asking. As a caregiver, as a professional, you have to try to answer some of these questions for your patient. You will not have all the answers, but you could provide as many as you can in an appropriate manner. A lot of times patients don't like us because we have to deliver bad news or we cause them pain. That is hard because we know that we are just trying to help. And sometimes that's just who the patient takes it out on. And that's not anyone's fault. No one's trying to do it. And I don't think they're even trying to be rude or malicious to us. It's just that's who it's coming out on. Some patients may just want to cry on your shoulder. If they got a diagnosis that wasn't particularly fond of, sometimes that's what they need. And every patient is different in how they react. I will say that over and over and over again. But we have to be respectful of everyone's emotions and how they're responding in that recovery process. A lot of the patients kind of reach to us for our skilled knowledge and what we know and what we understand. Be careful what you're giving to your patient. Make sure that you're thinking about what you're saying before you're actually speaking with your patient, because you don't want to give them false hope or misinformation. That can be bad. If they are a cancer patient, stage 4, and there is a slight possibility that they can get better, but there's more possibility that they will probably die from the disease. And you want to make sure that you are being positive enough, but also giving the facts of what's happening or what's going to happen, all in the scope of your practice as well. So don't give them information that their oncologist should be giving them. That's on them. Family meetings can help keep the patient and family on track. That sort of brings everyone in one room. Everyone talks together about what's happening. And so everyone's on the same page, and using layman's terms is really going to help with that. All of patients are affected differently with healthcare costs. Think about what's happening right now and how many Pennsylvanians are losing their job. Not just Pennsylvanians, all over the United States. How many people are losing their jobs because of what's happening with the COVID-19? Lack of finances can happen to anyone. It's not necessarily, we have to think about the factors coming into a non-compliant aspect. When you think of non-compliant, a non-compliant is a patient not taking a prescribed medicine or following a prescribed course of therapy more on their own accord. They're not doing it because they don't want to do it. They don't feel they need it. A patient, you might think that a patient is non-compliant, but we have to think outside of those factors, where if a patient was fired from their job and they no longer have insurance, they may not be able to pay for a $100 physical therapy visit. That's not necessarily non-compliant. That's more an economic factor and financially strapped over a non-compliant issue. A non-compliant is more that you are giving the patient the things that they need and the patient isn't doing that course of therapy. Making sure that as a professional, we are always advocating for our patients. So if there's any way that we can go around that, not around it to be sneaky, but to help your patient in a way that's legal, that's going to be more beneficial. Also, when our patient comes in, they're going to start reevaluating some of their relationships depending on what the problem or issue is. So they're going to reevaluate relationships, life, things that were left undone that they haven't done yet. This is for both terminally, it seems more for terminally ill patients, but it can really be anything that makes your patient kind of change their attitude or tone. Some people turn to religious beliefs. Some reach out to people from their past or reconnect with, and some like a bucket list. Mine, I always wanted to go to Italy. I still do. Just to kind of finish it. That's where my dad's family is from, and I've always wanted to see where they come. But some of these stressors push different priorities in an order of focus and what's really important in these relationships. Some people who were worried about work and meeting a deadline and getting this done, and then they have a terminal illness, might go, that wasn't really the important thing in my life. My family was. And you'll see these sort of switch around. But that is it for Chapter 7. Please let me know if you have any questions, and I will talk to you in Chapter 8.